moving on, we have a next presentation, Poverty Reducing Palliative Care in Malawi, presentation from Dr. Maya Jane Bates.
I was walking down the hospital corridor in Queen Elizabeth Central Hospital, Blantyre in Malawi, and I bumped into a nursing colleague and friend of mine. I knew that her husband was suffering from a common HIV-related cancer, non-Hodgkin's lymphoma, and had received treatment from our hospital. Chatting to her, I was sad to hear that her husband had actually passed away. But I was saddened even further to hear that she'd sold the truck. She'd sold some land. Her daughter had had to drop out of college in order to provide the treatment, which ultimately had been non-beneficial. This and other reflections from my medical life in Malawi led me to conceive of some work which I'm going to present to you this morning. And as I explored this area further, I was able to explore some of the background research that had been done in other countries far from Malawi, which I'm going to present to you first, and we'll end just before lunch with a bit of light relief, I hope, in the form of a short animated film which summarizes the research which I undertook myself. I learned, first of all, that data from the Center to Advance Palliative Care in New York, led by Diane Meyer and colleagues, had really led to an expansion of palliative care services. They looked particularly at health system costs. As many of you may know, in the States, care is driven by health insurance. And so health insurance providers are looking at how much they're going to have to pay out in order to support the care of any individual patient. And they were able to look using hospital billing data at total costs before and after palliative care consultation was introduced. As we can see here, this was robust data which showed that these total costs of care were dramatically reduced. And as a result of this and other data, health economic data coming out of the States, they were able not only to move palliative care from hospice, where you'd had to have a diagnosis of a prognosis of 6 months or less to receive care, into hospitals, and vastly increase the number of hospital-based teams. And this was all on the basis of health economic data. This is a quotation from Richard Horton, who many of you will know is the editor of The Lancet, and I think it encapsulates very clearly and precisely what we're kind of up against as we're thinking about service development. Many people in the room will be moved, and many of us, all of us, have been moved by stories today, but it's economists who are the ones who decide, and they model, and they think, and they produce data, and we're often not there at the tables when they are deciding the priorities for global health. So as doctors, as nurses, as health workers, in whatever field we're in, we have to begin to engage the language of economists, and particularly health economists. Data from closer to home, the ACTION study, this data came out more than, I think, 10 years ago, 2015. They studied over 10,000 individuals who'd received a diagnosis of advanced cancer in 8 countries from Southeast Asia. And the major finding from this study may not surprise us, but 75% had either died or faced financial catastrophe 12 months after their diagnosis of cancer. This and other data has led to this term, which we've heard plenty of times this morning, financial toxicity. So we think about drugs causing side effects, causing toxicity, but increasingly it's recognized that care itself in some forms can cause a toxicity of its own to finances. And this is recognised in the third pillar of universal health coverage, where we're looking at access to services, we're looking at which services are offered, but we're also critically looking at financial protection, and particularly thinking about what do people have to pay out of pocket, because in many of our systems, health insurance may be there, but a lot of these services are reliant on out-of-pocket costs. So let me take you briefly to the beautiful land of Malawi. It's a little bit further down the road from the country which our previous presenter has done her work in, Ethiopia. It's a small country in South Central Africa. It's well known for its beautiful freshwater lake, which takes up about 2/3 of the eastern border. We don't have earthquakes, but our major catastrophes are caused by flooding. And we've had major floods in recent years, which have devastated the main crop, the maize, which everybody relies on for their daily meal of nsima. Some brief stats from Malawi. Our population is 20 million. Median age, life expectancy is fairly similar to this part of the world. And as we've encountered, we have largely a rural subsistence farming economy. Healthcare services are mainly provided through taxation, funded by the Ministry of Health and the Christian Hospital Association in Malawi, which runs many of the former mission hospitals across the country. Common illnesses that we see are TB, HIV, and malaria, but of course we're also facing rising numbers of road traffic accidents, as well as NCDs. I've had the joy and privilege of being involved with others to see the development of palliative care, which has been led both by the Ministry of Health and by the Palliative Care Association in Malawi. And whilst not perfect, not comprehensive, and far from meeting all the quality standards, we have reached some significant goals over the last 15 to 20 years. And this was a place where, with colleagues, I was able to work both at the government teaching hospital, in teaching, training, developing services, and finally in research. Through one of the EMMS-funded projects, health workers from our team and other teams would go to district services and help support the workers there become trained. This is familiar, isn't it? A familiar story as to how we expand and extend palliative care access outside of the cities and into the rural areas. One of the reports from colleagues showed that a patient that they'd seen had been experiencing significant cost for his diagnosis of Kaposi's sarcoma, again, a common HIV-related cancer, particularly found amongst men in the population of Malawi. He'd been treated inappropriately with one-off doses of pethidine, and he'd been spending much of his money in private hospitals. We know that ill health worsens poverty. Sometimes we have to think a little bit carefully about the many ways in which ill health can worsen poverty. It affects time for patients, but also for their guardians or family members who lose their working time in taking patients to hospital. Many people have to borrow money in a concept known as dissaving, and dissaving is being measured by people as they gather data in this area. So what happens when we effectively treat pain and listen to people talking about their illnesses? We've heard a lot about this morning, and some tremendous stories that we'll carry with us, I hope, and give us courage and give us strength as we continue our work in our different places. But also, palliative care has an impact on poverty. And Adam Wagstaff, one of the World Bank economists, brought up the idea of the poverty trap, which comes in a simplified diagram like this circle, where families' income is reduced, and this reduces the capability of a household, which in itself leads to poor levels of education, which leads to late presentation of illness, late diagnosis of illness, and that then increases the need for high expenditure leading to catastrophic costs on illness, and continues that cycle that we've heard about already in many of the stories today. And there are several ways in which palliative care can impact this poverty trap and the cycle of poverty. Sometimes, as we've heard earlier, we may catch patients at an earlier time. We can help to treat their pain, and they can in fact return to work. For others, through careful counselling and reintegration into the community, we reduce the significant community and society discrimination that they find, and they can engage once again. And hopefully, as I mentioned at the beginning, we can try to reduce some of the non-beneficial costly care. Obviously, we want people to receive the care that they need for any reversible elements to their illness, but there are elements that are perhaps futile, perhaps non-beneficial, and we want to try to help negotiate their illness pathways and reduce those costs on non-beneficial care. So I'm going to finish my presentation with a short film, which hopefully will play, just to summarize some of this that I've talked to you about already, and also the research that I was involved with.
No one really wants palliative care, or do they? Palliative care reduces the serious health-related suffering of adults and children in households affected by life-limiting illnesses such as stroke, cancer, and heart failure. It is integral to universal health coverage. The World Bank and others endorse palliative care as a value-for-money intervention which supports poverty reduction at household level. Despite this, access to palliative care remains at critically low levels in most low and middle-income countries around the globe, and its role remains widely misunderstood in global health. We undertook research in Malawi, a low-income country in South-Central Africa, with patients and families who had experienced a diagnosis of advanced cancer. They used photo voice to tell the story of their illnesses, how they understood well-being, and the role of palliative care. Milika is 37 years old. She works for a scrap metal merchant, but her work is disturbed when her leg starts to swell. After several trips to the hospital, she is told she has advanced cancer. More visits to hospital means more money for transport and to buy some of the medicines the doctors ordered. Milika stays at home, no longer able to work or walk because of her painful swollen leg. The community-based palliative nursing team sees Milika, and following assessment, she starts taking oral liquid morphine, which helps to reduce her severe pain. She finds courage to start working again, and her children return to school. We conducted a study in which we asked 150 households to record where they went to get help and how much it cost them. We measured out-of-pocket costs following a diagnosis of advanced cancer, looking specifically at what happens when households receive palliative care. We proposed that out-of-pocket costs could be reduced by controlling symptoms and through patient-centered communication, reducing the need for non-beneficial care. Take, for example, Jeff. Jeff is 50 and he is bedridden with a brain tumor. His family members are trying to decide whether to sell some fields and a truck from their maize business to pay for him to travel outside the country for treatment. With the help of the palliative care team, they arranged to visit the village elders to discuss how best to support Jeff with his advanced illness. The family decide to care for Jeff at home, allowing him to die comfortably rather than spending money on non-beneficial costly care. In our study, we found that almost 2/3 of households faced catastrophic out-of-pocket costs following a diagnosis of advanced cancer, compared to less than half when they received palliative care. But only 1 in 5 households with advanced cancer received palliative care. Investment in palliative care reduces suffering and promotes future household health and well-being. No one really wants palliative care. Or do they?
Just to acknowledge particularly the patients and families who are engaged in the research, and the supervisory team, research team, and funding bodies who helped with the conducting of the research. Thank you.
For that wonderful presentation. The health economics is the key, I think. And how do we get the message to the policymakers that palliative care actually saves money for the patient, the family, and also for the nation, actually. So thank you so much for the presentation.